على المalignant lesions of the body of the uterus. Now انتوا بتعرفوا انه الuterus is made up of the body and the cervix. Now cervix is completely different. Cervical cancer is a completely different type, and you will have a separate lecture for cervical cancer. Now, when we are talking about the body of the uterus, we are talking about benign and malignant. So the commonest benign tumor is the fibroid. And again, the fibroid, there will be a separate lecture. So we will talk today about the malignant lesion of the body. The body of the uterus is made up of endometrium and myometrium. So the malignant tumor of the myometrium, it is a smooth muscle, and this is why we call it leiomyosarcoma. So the uterine leiomyosarcoma is the malignant myometrial tumor. The endometrial tumor, endometrium, is made up of glands and stroma. Any tumor from the glands, we call it adenocarcinoma. So it's endometrial adenocarcinoma. Anything arising from the stroma, we call it sarcoma. So it's an endometrial stromal sarcoma. Now, sometimes the tumor might arise from both the glands and the stroma, and in that case, we call it uterine carcinosarcoma because it's a combination. The old name for it was the malignant mixed Mullerian tumor, triple MT, malignant mixed Mullerian tumor. The new name is the carcinosarcoma. Now, stromal sarcoma, carcinosarcoma, or leiomyosarcoma, these are extremely rare tumors, and they are very aggressive. And this is why we will briefly touch on them. They are rare, aggressive tumors. Now, the commonest is the endometrial adenocarcinoma. Now, before we talking about endometrial adenocarcinoma, we have to talk about what we call endometrial hyperplasia. Hyperplasia means increase in the number of endometrial cells on both the glands and the stroma. It could be simple, it could be complex hyperplasia. So we have simple hyperplasia and we have complex hyperplasia. And with the simple or complex, we will have either no atypical cells or there is atypical cells. So at the end of the day, we have 4 types of hyperplasia. We have the first type, which is non-atypical hyperplasia. In other words, hyperplasia without atypia or without atypical cells, just increase in the number of the cells. This could be simple and this could be complex. It could be hyperplasia with atypia, with cell atypia, and in that case, again, it could be simple or complex. So simple atypical, complex atypical, simple typical, complex typical hyperplasia. The reason for this subclassification is because of their risk of transformation into cancer. Each one of these 4 have different risk of transformation into cancer. So simple hyperplasia without atypia, risk of transformation is 1% if left untreated. Complex is 3%. Simple with atypical cells is around 8%. And complex with atypical cells is around 30%. So this is the different rates of progression into cancers. Now, hyperplasia is a pre-malignant condition and usually confined to the endometrium. If left untreated, it can lead to endometrial carcinoma. So simply the treatment would be simple hysterectomy. If you just remove the uterus, you will cure the patient, and that's it. Now, sometimes the patient is not willing to have a hysterectomy. She wants to keep her uterus, and in that case, we can offer them medical treatment in the form of progesterone. There are different formulations of progesterone. It could be cyclical, could be continuous, could be injections, could be oral, different forms. But the bottom line is you give them progesterone and you need follow-up. You just repeat the biopsies after 3 months to make sure that the changes have been corrected. Now, if endometrial carcinoma develops, now, this is a disease of postmenopausal women. Usually it happens around the age of 61. This is the peak incidence or the average age. Only 5% occur before the age of 40. Very rarely you'll see endometrial cancer in young age group. The only group you can see them اللي هم المرضى اللي عندهم polycystic ovarian disease and they are not treated. There are marked geographical and racial differences in the incidence. يعني الداتا the data which we know say that it's very common in the Western countries. The incidence of endometrial cancer actually is increasing worldwide, and the reason for that is obesity. Obesity is an important risk factor for endometrial cancer, and as you know, obesity is becoming a pandemic. So the incidence of endometrial cancer is increasing worldwide. Basically, there are two types of endometrial cancer, and then type 1 and type 2. The type 1 endometrial cancer, or they call it the endometrioid, which is the commonest type. Now, this is an estrogen-dependent tumor. This is related to the estrogen. So, patient will have high estrogen exposure, and she will develop the endometrial type. It's usually adenocarcinoma. The pathology is usually well-differentiated type, and it's diagnosed in the early stages, and therefore the prognosis is excellent. The less common type اللي هو type 2 أو non-endometrioid, it's usually either serous or clear cell, which can happen in around 15% of the cases. This type has nothing to do with estrogen. It's non-estrogen dependent. The pathology is poorly differentiated, and it is advanced stage, and it carries a bad prognosis, and usually it behaves in similar way to ovarian cancer. تعرفوا انه type 2 endometrial cancer type 2 احنا من ناحيه التريتمنت والمانجمنت والبروجنوسيس we deal with it as ovarian cancer in the same way. So what about the type 1? What's the main etiology? To have a healthy endometrium, the endometrium has to be exposed to both estrogen and progesterone in constant proportion to each other. If your endometrium is exposed to estrogen alone, this is bad, and that can cause stimulation of the endometrium, which will lead to hyperplasia, and eventually it will lead to endometrial cancer. So progesterone can reverse this growth. Typical risk factors for endometrial cancer, you will see obesity, higher age group, patient with polycystic ovarian syndrome, patient with diabetes, patient receiving tamoxifen for breast cancer, and exogenous estrogen patient receiving hormone replacement therapy. Of course, there are small group of patients who have a familial inheritance for cancer, what we call the Lynch Syndrome, or the hereditary non-polyposis colorectal cancer. Those patients are at higher risk of endometrial carcinoma. The same thing, combined and the progesterone are protective against endometrial cancer, and they reduce the risk and the incidence. There are reports that smoking reduce the risk of endometrial cancer, but these are just reports. Okay. The commonest symptoms for postmenopausal bleeding for endometrial cancer is postmenopausal bleeding, and therefore postmenopausal bleeding is a very serious symptoms. And what I really need you to know, يعني المسج يمكن if I want a message from this lecture is just to know that any patient with postmenopausal bleeding should have endometrial biopsy to rule out endometrial cancer. Okay. Again, what other symptoms? It might be irregular periods or heavy periods. Sometimes they have biometria or offensive vaginal discharge. Pain is not a typical symptoms for endometrial cancer. Pain is usually a late symptom. Yani, by the time the patient develops pain due to endometrial cancer, it's usually advanced stage. And this is why, because most of our patients, they usually present in the early stages, their clinical physical signs are usually limited. Yani, hardly you will have any signs. The uterus might be slightly enlarged. In advanced cases, you might see a vaginal nodule, or you might have palpable lymph nodes in the groins or in the supraclavicular region. And like other tumors, it's spread by direct invasion into the adjacent organs. It can metastasize by the lymphatics to the pelvic and para-aortic lymph nodes, and rarely it can metastasize by the blood. Any patient with postmenopausal bleeding or abnormal bleeding after the age of 40 has to have the following investigations. First of all, you have to do cervical smear. You have to do a transvaginal scan. And particularly with patients with postmenopausal bleeding, transvaginal ultrasound will be very helpful to measure the endometrial thickness. Now, normally, the endometrial thickness in postmenopausal women is less than 4 millimeter because the endometrium is atrophic. If the thickness is more than 4 millimeter, this is a pathological, and it means that there is a pathology and a biopsy. As you can see in this graph, there is a suspicion of something inside the endometrial cavity. Then you have to do endometrial biopsy, and the endometrial biopsy can be done by hysteroscopy and curettage or DNC بنسميها. And then we send the pathology, and if that confirmed endometrial carcinoma, then we have to do a staging investigation, including pelvic MRI and chest X-ray. The prognosis of endometrial cancer will depend on several factors, including the stage of the disease, the grade of the tumor, the depth of myometrial invasion, the age of the patient, and the tumor size. Now, most of these factors are not available until you have done the surgery, and this is why it's called surgical pathological staging for endometrial carcinoma. Unlike endometrial ovarian cancer, endometrial cancer is usually present in the early stages, and therefore the treatment is basically surgical. So surgery is the hallmark of treatment of endometrial cancer. So in the tumors which are confined to the uterus, is basically you remove the uterus and both ovaries. Sometimes you have to do pelvic lymph nodes dissection in certain groups of patients. مش مهم تدخلوا في التفاصيل تاعتها، بس يعني المهم تعرفوا انه احيانا we have to do lymph node dissection, and patients who have adverse risk factors also they receive post-operative radiotherapy adjuvant radiotherapy. The same thing applied for stage 2, which means that the cervix is involved as well. So in that case, you have to do the surgery followed by radiotherapy. Now, when we are talking about stage 3 and 4, it means that the disease is disseminated into the peritoneal cavity or distant metastasis. And in that case, in this case, the treatment will be individualized. So either it's a combination of surgery, radiotherapy, and chemotherapy, not single treatment. Okay. The prognosis for endometrial carcinoma is generally good. Endometrial stromal sarcoma, as I mentioned, it's extremely rare tumor. Endometrial stromal sarcoma or carcinosarcoma, they occur in Black patients who have previous pelvic radiotherapy. They usually present with pain and bleeding, and the prognosis is very bad. Just to know how bad these, بالنسبة للcarcinosarcoma, we are talking about 2 years survival data. There are no 5-year survival data, which means that majority of patients are dead. Okay. Leiomyosarcoma. Again, leiomyosarcoma is a rare tumor, which means it is a malignant tumor of the myometrium. If a patient is having a void, there is a small risk that it can be transformed into sarcoma. The risk is around 2 per 1,000. So 2 per 1,000 risk of sarcomatous transformation of fibroid into sarcoma. However, most of leiomyosarcoma, they arise from a normal myometrium. They are not preceded by fibroid. Usually the presentation is pain with bleeding. Majority of the cases, the CT scan, the ultrasound, the clinical presentation will not be able to differentiate between leiomyosarcoma and leiomyoma, and the fibroid. So in majority of the cases, the diagnosis is made up after the surgery. However, what I really need you to know that 2 things. Fibroids are slowly growing tumor. Now, if the fibroid become growing quickly, suspect that it change into sarcoma. The other scenario, fibroids tend to regress in size after menopause, and it becomes smaller. Now, if the fibroid starts growing after the menopause, again, suspect sarcomatous changes. As I mentioned earlier, the prognosis for these is very bad. The treatment is usually by surgery to remove the uterus and the ovaries and the tumor. And there is little benefit from adjuvant chemotherapy or radiotherapy. It might be beneficial in controlling the symptoms, but it doesn't improve the survival. And the prognosis for these cases is very bad. Okay. And by this, we have finished this lecture. Any questions?